talk about something which is very controversial. So that is direct oral anticoagulants are better as compared to warfarin. So now let's talk about that in detail. So what are the direct anticoagulants that you know? So these are the factor 2 inhibitors. These are basically rivaroxaban and dabigatran. They are better as compared to warfarin because they do not cause that much bleeding that warfarin does, because they do not need constant monitoring and they will cause fewer drug interactions as compared to warfarin. The short half-life of the newer anticoagulant drugs will make them will increase the risk of thromboembolism in patients that do not comply to the normal regime of medicine taking. Given the convenience of once or twice daily oral dosing and fewer drug interactions, the new direct oral anticoagulants have replaced warfarin. Now let's talk about thrombolytic drugs. For that, we have TPA derivatives, and then we have streptokinase. So please remember TPA derivatives as well as streptokinase, urokinase, and then also remember tenecteplase, alteplase, tenecteplase, as well as reteplase. So for that, I have the mnemonic of straw for you. Streptokinase is from a protein, and all the other TPAs are the derivatives of. They are basically all places. Now let's talk about their mechanism of action. So plasmin is an endogenous fibrinolytic enzyme that will degrade clots by splitting fibrin into fragments. Thrombolytic enzymes will catalyze the conversion of plasminogen into plasmin. So that is a mechanism of action that they are going to convert plasminogen into plasmin. Then let's talk about TPA, which is tissue plasminogen activator. It is an enzyme that will convert plasminogen into plasmin. It has little activity unless it is bound to fibrin, which should make it selective for plasminogen that has already been bound to fibrin. For example, that is a clot, and should result in less danger of widespread production of plasmin and spontaneous bleeding. At the pharmacological level of TPA using thrombolytic therapy, phosphospacity is lost. Alteplase is a recombinant human plasminogen activator. Reteplase is a mutated form of TPA with similar effects but a slightly faster duration of action and longer duration of action and faster onset of action. Tenecteplase has a fastest or longest half-life. It is also a mutated form. So R and T are mutated forms, and alteplase is a recombinant human plasminogen activator. Then let's talk about streptokinase. This shit is expensive. Streptokinase is obtained from bacteria, and that causes it to cause allergies in specific patients. Although not itself an enzyme, streptokinase will form a complex with plasminogen. So it is not an enzyme itself, so it will form a complex with plasminogen. Plasminogen streptokinase complex will undergo a conformational change that will allow it to rapidly convert free plasminogen into plasmin. Unlike the forms of TPA, streptokinase does not show selectivity, so it is non-biased for fibrin-based plasminogen. Urokinase is a human enzyme synthesized by the kidney that directly converts plasminogen into plasmin. So it is synthesized by kidney. That is a uro. Then major application of the thrombolytic agents is as an alternative to percutaneous coronary angioplasty in the emergency treatment of coronary artery thrombosis. Under ideal condition, that is a treatment within 6 hours, these agents can recanalize the occluded coronary vessel. They are given in arteriosclerosis, atherosclerosis, very prompt if given within 6 hours. Very prompt use, that is within 3 to 4 hours or 3 to 4.5 hours of the first symptoms of the TPA in patients with ischemic stroke is associated with a significantly better clinical outcome. Cerebral hemorrhage must be positively ruled out before, otherwise streptokinase will cause severe internal bleeding. The thrombolytic agents are also used in cases of very severe pulmonary embolism. Now let's talk about their toxicity. Toxicity. Bleeding is the most common hazard and has about the same frequency with all the thrombolytic drugs. Cerebral hemorrhage is the most serious manifestation. Streptokinase, which is a bacterial product, it can evoke the production of antibodies that cause it to lose its effectiveness or induce severe allergic reaction on subsequent therapy. Patients who have had streptococcal infections may have preformed antibodies to the drug. Because they are human proteins, the recombinant form of TPA is not subject to this protein. However, they are much more expensive than streptokinase and not much more effective. Now let's talk about antiplatelet drugs. These drugs contribute to the clotting process. Platelet aggregation contributes to clotting process. And it is important in clots that form in the arterial circulation. Platelets play a central role in pathological coronary and cerebral artery occlusion. Platelet aggregation is triggered by a variety of mediators released by the platelets, which are, for example, prostaglandin, thromboxane, ADP, thrombin, fibrin. Substances that increase the cyclic AMP. For example, prostacyclin, adenosine. Substances that increase the intracellular cyclic AMP or CAM, for example, prostacyclin, prostaglandin, adenosine, inhibit the platelet aggregation. Now let's talk about classification and prototypes. So we can classify them as antiplatelet drugs will include aspirin, for example, NSAIDs, for example, aspirin, glycoprotein 2B or 3A receptor, for example, abciximab, tirofiban, and eptifibetide, tirofiban, and abciximab. Abciximab is the most important one. Antagonists of the ADP receptor, for example, clopidogrel, prasugrel, and ticlopidine. Ticlopidine is what? It is an ADP receptor inhibitor. Then we have antagonists of the PAR1, which is protease activated receptor 1. For example, Vora, Paxar, and then we have inhibitor of adenosine or phosphodiesterase E or phosphodiesterase 3. These include cilostazol and dipyridamole, and cilostazol. Let's talk about PAR1 again. This includes Vora, Paxar. Aspirin and other NSAIDs will inhibit thromboxane synthesis by blocking the cyclooxygenase pathway. Thromboxane A2 is the potent stimulator of the platelet aggregation. Aspirin is an irreversible COX inhibitor. It is particularly effective because platelets lack the machinery for protein synthesis. Inhibition by aspirin will persist for several days until new platelets are formed. And other NSAIDs which cause a less persistent antiplatelet effect for hours are not used as antiplatelet drugs, and they can interfere with the antiplatelet effect of aspirin when used in combination with aspirin. So plasminogen, when converted into plasmin, it is stimulated with the help of fibrinolytics, including the TPA analogs, for example, alteplase and streptokinase and plasminogen as well. These are also included in thrombolytics. But antiplasmin drugs, which will inhibit the conversion of plasminogen into plasmin, include the aminocaproic acid and tranexamic acid and aminocaproic acid. So fibrinogen conversion to fibrin is going to be stimulated with the factor 2 or thrombin. This will split the proteins. Fibrinogen will lead to the production of degradation proteins. Now let's talk about what will bind to the glycoprotein 1A receptor. So it is going to bind to collagen. Glycoprotein 1B receptor is going to bind with von Willebrand factor. Glycoprotein 2B3 or 3A will bind to fibrinogen and other macromolecules. PGI2 is released from endothelium, and what is released from platelets? Thromboxane A2 as well as ADP. Arachidonic acid, phosphodiesterase, E. Now let's talk about the abciximab will cause a binding of fibrin and other ligands to the platelet. But tirofiban and eptifibetide, they are going to reversibly inhibit or irreversibly block the receptor of glycoprotein 2B or 3 receptor. Then let's talk about the adenosine inhibitors like prasugrel, clopidogrel. They are the ticlopidine, which is older drug. They are converted in the liver to active metabolites that will irreversibly inhibit the ADP receptor, and they will prevent ADP-mediated platelet aggregation. Then we have ticagrelor. This is a new drug that does not require activation, and it will inhibit the platelet ADP receptor. Vorapexar is from PAR1 or protease activated receptor 1. It is a reversible antagonist of protease activated receptor 1. They are expressed on platelets. Its longer half-life makes it effectively irreversible. It will inhibit the TRAP, which is thrombin-induced and thrombin receptor agonist peptide, and induce platelet aggregation in vitro studies. It is metabolized through CYP3A4 and CYP2J2. Dipyridamole and cilostazol, they will have a dual mechanism of action. They will prolong the platelet inhibition action of the intracellular cyclic AMP. They will inhibit the phosphodiesterase enzymes. They will cause inhibition of the prostaglandin or prostacyclin that will degrade the cyclic nucleotides, including cyclic AMP, and inhibitor of platelet aggregation, and CGMP, a vasodilator. They will inhibit the uptake of adenosine by endothelial cells and erythrocytes and will increase the plasma concentration of adenosine. Adenosine will act through the platelet adenosine A2 receptor to increase the platelet cyclic AMP and inhibit the aggregation. Let's talk about the clinical uses. So aspirin is used to prevent infarcts in persons who have had one or more myocardial infarcts. This drug is used extensively to prevent transient ischemic attacks, ischemic stroke, and other thrombotic events. Then let's talk about glycoprotein 2B or 3A inhibitor like abciximab. It is going to prevent stenosis after coronary angioplasty, and it is also used for short periods in acute coronary syndromes, unstable angina, and non-Q wave acute myocardial infarction. Then we have clopidogrel and clopidine. They are very useful in treating transient ischemic attacks and ischemic strokes. So strokes and attacks may use with you. Like Purine 2B3A is going to prevent restenosis. GR aspirin is used in patients who have had a lot of attacks, and clopidogrel and clopidine stroke. And also in patients who cannot tolerate aspirin. Clopidogrel is routinely used for 6 to 12 months with aspirin to prevent thrombosis in patients after placement of stent. Then we have dipyridamole, which is used as an adjunct to warfarin. So warfarin plus dipyridamole will prevent thrombosis in patients who have had cardiac valve replacement, so DW. And don't worry, it has also been used in combination with dipyridamole is also used in combination with aspirin for secondary prevention of ischemic stroke. For stroke, we give DW, and for prevention and for secondary prevention of ischemic stroke, we're going to give DA, dipyridamole and aspirin. Cilostazol is used in the treatment of intermittent claudication, manifestation of peripheral arterial disease. Now let's talk about toxicity. Aspirin and other NSAIDs, 6 tablets and you're gone. It is going to cause GIT and CNS effects. Aspirin and other NSAIDs. All antiplatelet drugs will significantly enhance the effects of other anti-clotting agents. The major toxicities of the glycoprotein 2B or 3A receptor blocking drugs are abciximab, eptifibatide, and tirofiban. They're going to cause bleeding and bleeding. And with chronic use, they're going to cause thrombocytopenia. Ticlopidine is used rarely because it causes, what is ticlopidine? ADP inhibitor. Ticlopidine is rarely used because it causes severe neutropenia in about bleeding in 5% of patients and severe neutropenia in about 1% of the patients. It is and rarely thrombotic thrombocytopenia or TTP, which is characterized by disseminated formation of small thromboplatelet consumption and thrombocytopenia. Clopidogrel is less hemotoxic, and the most common adverse effects of dipyridamole and cilostazol are headache and palpitation. Cilostazol is contraindication indicated in patients with congestive heart failure because of evidence of reduced survival. Let's compare heparin with warfarin. So the structure of heparin is that it is a large acidic polysaccharide polymer. And warfarin is just a small lipid-soluble molecule. The route of administration of heparin is always parenteral, and warfarin is always oral. Site of action, heparin blood, warfarin liver. Onset of action, rapid, in minutes of heparin. And warfarin is very slow, days, limited by half-lives of pre-existing normal factors. Mechanism of action of heparin. Activation of antithrombin 3, which will inactivate the coagulation effects factors, for example, 2 and 10A. Inactivation of 2 and 10A factors by activation of AT3. Warfarin, mechanism of action, conversion. It will impair the post-translational modification of vitamin of factors 2, 7, 9, and 10. And then monitoring for heparin APTT, but for unfractionated heparin, but not for low molecular weight heparin. Warfarin PT or INR. Antidote for heparin, protamine. For unfractionated heparin, protamine reversal of low molecular weight heparin is incomplete. Warfarin, vitamin K, vitamin K1, or PCC in plasma. Fresh frozen in plasma. Use in pregnancy heparin? Yes. Warfarin? No. So there are some drugs which are going to be used in bleeding disorders which will cause clotting. They're from clotting, inadequate blood clotting is due to the deficiency of vitamin K, due to genetic abnormalities like those of hemophilia, a variety of drug-induced conditions, and thrombocytopenia. Treatment will involve administration of vitamin K, PCC, or antiplasmin drugs. Thrombocytopenia can be treated by administration of platelets or oprelvecin, which is a recombinant form of megakaryocytic growth factor, which is interleukin 11. Then we have vitamin K. Deficiency of vitamin K, a fat-soluble vitamin, is the most common thing in older persons and also in little infants. Older persons with abnormalities of fat absorption and newborn babies with the risk of bleeding due to circumcision. Due to vitamin K deficiency, the deficiency is readily treated with oral or parenteral vitamin K1, which is phytonadione. In the US, all newborns receive injection of phytonadione. Large doses of vitamin K1 are used to reverse the anticoagulant effect of excessive amount of warfarin, clotting factors, and desmopressin. The most important agents used to treat hemophilia are fresh frozen plasma and human blood clotting factors, including 2, 7, 9, and 10. Factor 8, 9, and 11. So factor 8 is for hemophilia A, factor 9 is for hemophilia B, which are either purified from blood products or produced by recombinant DNA technology. These products are very expensive and they carry a risk of immunological reactions, and in the case of factors purified from the blood products, infection can occur. Infection, although most known blood-borne pathogens are removed by chemical treatment of the plasma extracts. Then we have vasopressin V2 receptor agonist. Desmopressin acetate will increase the plasma concentration of von Willebrand factor and factor 8. In patients who have been elected for elective surgery, who have a deficiency of hemophilia A or von Willebrand disease, we are going to give desmopressin acetate, which will increase the plasma concentration of the von Willebrand factor and factor 8. Then we have antiplasmin agents. Antiplasmin agents are valuable for prevention or management of acute bleeding episodes in patients with hemophilia and others with a high risk of bleeding disorders. Aminocaproic acid and tranexamic acids are orally active agents that inhibit the fibrinolysis or the conversion of plasminogen into plasmin. By inhibition of plasminogen activation, then fibrin will not be formed. So for that, tranexamic acid and aminocaproic acid. TA or AT. Adverse effects include thrombosis, hypotension, myopathy, diarrhea. ABTT test is a test which is used to monitor the anticoagulant effect of unfractionated heparin and direct thrombin inhibitors. It is prolonged when drug effect is adequate. Then we have 83, which is given in combination with the heparin, UFH. Then we have clotting cascade with a system of serine proteases and substrates in the blood that provide rapid generation of clotting factors, resulting in fibrin clot in response to damage of the blood vessel. Then we have glycoprotein 2B or 3A. It is a protein complex on the surface of the platelet. When activated, it will aggregate the platelet primarily by binding to fibrin. Endogenous factors including thromboxane A2, ADP, serotonin will initiate a signaling cascade that will activate GP2B or 3A. Then we have HIT, which is a hypercoagulable state, plus thrombocytopenia that occurs in a small number of individuals with UFH. Then we have INR, which is a measured coagulation time in PT test, expressed as ratio to international standard. Ratio of 1 is normal coagulation time. Anticoagulation increases ratio to greater than 1. And then we have low molecular weight heparin, which is fractionated preparation of heparin of molecular weight 2,000 to 6,000, and fractionated heparin has a molecular weight of 15,000 to 30,000. Then we have PT test, laboratory test, which is monitor the anticoagulant effect of warfarin prolonged when drug effect is adequate.